Hello and welcome everyone. The WMFC is proud to host you for what will be a very informative session with Dr. Stephen Treon. Thank you for being here. My name is Brenda Rogers and I live in Vancouver, BC and facilitate the BC WM support group called the BC Wallies through the WMFC. Our session is going to begin shortly, and for those wondering, yes, we will be recording for future availability. And just so everybody knows, if you look at those orange circles sort of down towards the middle bottom of your computer screen, that's where you'll find the chat box, and anything you type in the chat box is shared with everyone. And there's also the Q&A box that's right there, where you can privately submit questions to Dr. Treon during our Q&A period. Feel free to use those throughout the presentation as a question comes to mind, and we'll cover those during the Q&A. And for right now, there is also the restore button. If you move things around on your screen and then need to move them back, you'll hit restore. And again, there's the chat button and the Q&A button to submit your questions. And now I'd like to introduce Mr. Cam Fraser, who is the president of the WMFC. Hello, Cam.
And I appreciate that. That's terrific. I've gone from chair to president. I think that's probably a good promotion. Anyway, I'd like to welcome you all to our second Treatment Advances in WM for Canadian Doctors and Physicians by Professor Steve Treon. I'm thrilled at the turnout we've got here tonight, despite the demands of COVID on our medical community. The Waldenstrom's Macroglobulinemia Foundation of Canada is the sponsoring of this event and is provided by a generous grant, education grant by Beijing, Canada. The WMFC is an entirely volunteer foundation dedicated to patient support, education, and research to find a cure for WM. Trying to find another WMer to share your experiences can be a very difficult chore. So WMF currently has established 9 support groups in most of the major cities across Canada, from Victoria to Halifax. We would normally hold in-person meetings, but with COVID, all our meetings are currently on Zoom. Hopefully to change soon. From an education standpoint, for patients, the WMC organizes annual in-person education forums, alternating across the country and inviting expert speakers from across North America. Unfortunately, our upcoming Calgary Ed Forum has had to be postponed, of course, by COVID, or due to COVID. We have built a website as well to update WMers for all WM information, loaded with articles and webinars to assist in the understanding of this rare disease and recently how it interacts with COVID. We also organize presentations like this to update the medical community on changes in WM diagnosis and treatment. Regarding research, 80% of all our donations go to research for a better or cure of treatments of WM. Last year, we funded a grant to Dr. Hunter of the Bing Center at Dana-Farber for $200,000 US to continue down the road for a cure to WM. Together, we have made significant improvements, but we are not there yet. What we would like is for each of you, when you see a WM patient, is to refer them to our website, which is wmfc.ca, which will answer a lot of the questions they may have and keep them up to date on their WM journey. Now, Professor Treon, I suspect, doesn't need much of an introduction, but he is currently the director of the Bing Center for WM within the Dana-Farber Cancer Institute in Boston. He is also professor of medicine at Harvard Medical School. Professor Treon, the Bing Center, and Dana-Farber Cancer Institute have combined to make significant advancements in the treatment of WM through his research and literally seeing hundreds of WM patients. He's offered a wealth of experience in treating of this disease. They are also strong supporters of the International WM Foundation in the US, as well as the WM Foundation here in Canada. Professor Treon is very active on the WM Scientific Advisory Board, designing and implementing a roadmap for a cure to WM. So I am honored to introduce Professor Stephen Treon.
The honor is really all mine. It's really a pleasure to be here tonight and to be able to share this progress being made in Waldenstrom's macroglobulinemia. And in fact, a lot of progress is being made. So this is going to be a great hour. So let me go on. I think The next slide that I have is one of my disclosures, which I'd like to share with you. And I also want to pause for a moment and thank BeiGene Pharmaceuticals for making this program possible. So I think many of you are familiar with the manifestations of Waldenström, but it's worth reviewing because it just shows you how differently patients can present. Of course, for most patients, it's the involvement of the bone marrow that produces cytopenias, most commonly anemia, as a important manifestation of disease. In fact, 70% of all patients present with anemia, but also important to remember that anemia can be multifactorial. Of course, it can be due to crowding of the bone marrow by tumor, but also the tumor cells can produce hepcidin. This is a very interesting protein that suppresses iron uptake from the gut, but it also causes macrophages, monocytes to sequester iron. And this can also produce anemia. And the one thing you should know is that if you work these patients up, do in fact check for an iron saturation level. And if it's low, typically 12% or less, using parenteral iron supplementation can be a way to help improve a patient's hemoglobin. Now, the anemia can also be caused because of IgM cold agglutinins. This we see at about a frequency of about 5%. But, suffice to tell you that there are multiple ways patients can present with anemia. Now, the IgM can also cause other problems. I'm sure you're familiar with IgM cryoglobulinemia, which we often see, particularly in the colder parts of the country, as an initial manifestation of disease. The IgM can bind to the myelin sheath of peripheral nerves and induce neuropathy. And just note, the incidence of this is quite high. In fact, many of our patients now are referred to us by neurologists. In addition to the heavy chain, there's also light chain amyloidosis, which we see usually in latter stage of disease as a manifestation. And of course, keep in mind that the IgM can induce hyperviscosity. And typically you do get epistaxis, headaches, or impaired vision due to retinal hemorrhaging when the IgM is above 60 grams per liter or 6,000 milligrams per deciliter, or if the serum viscosity is above centipoise. Now note, even though this is a lymphoma, it's very unusual at time of diagnosis to see extramedullary disease, but much more common at time of relapse. And then lastly, as the patients are living longer, you do see CNS disease. This can also present de novo, but more common in the relapsed setting. This, used to be extremely rare, but now as the patients are living longer, we see about 3 to 4 cases per month now of Bing-Neill syndrome. I'll talk a little bit about how we take care of patients who present with this manifestation. Important also to keep in mind that, a fair number of patients, even though they meet diagnostic criteria, do not require therapy. So keep these guidelines in mind, such as a hemoglobin of less than 10, platelet count less than 100,000. If they're symptomatic because of hyperviscosity, moderate severe peripheral neuropathy, or cryoglobulins, cold agglutinins, or autoimmune-related problems, or amyloid, fair game to treat. Otherwise, watch and wait. And just as an indicator in our group, where we see, over 1,000 patients a year with Waldenström, roughly 30% are so-called watch and wait patients. So it is a sizable population. And even Jan Waldenström used to say, let well do. So I think it's important to heed his advice. Now, traditionally, we've treated patients with Waldenström's with Rituxan-based therapy. This goes back to my old days when I helped in the development of rituximab. But you can see that when you use Rituxan as a single agent, overall responses are about 25 to 40%. Very seldom do you get deep responses, so don't count on a CR. And the benefit, usually lasts about a year to a year and a half. For which reason we and others over the years have looked at various combinations with Rituxan. And the ones that are most popular these days are the proteasome inhibitor combinations as well as bendamustine, where you can see overall response rates, up to 90%. But again, CRs are elusive. So the goal of therapy is really not to pursue a CR, but to alleviate symptoms and suffering. And, with this, you can see that major response rates are quite high, but so the progression-free survival of 4 to 6 years in the frontline setting can be accomplished with these combination therapies. But keep in mind that CR is not the goal of therapy, because often you see clinicians pushing for a CR, and unfortunately, many times what we see is toxicity. Speaking of toxicity, there are some toxicities that are very Waldenstrom-centric. With rituximab, we see the IgM flare. This can happen on the same day you're giving the first infusion of Rituxan. I've had patients double their IgM on that first day. This can occur in about half of all patients. And if you have somebody with a very high IgM, you can actually push them into hyperviscosity crisis. Usually, we are very careful with giving Rituxan to people who have an IgM above 40 or 4,000 milligrams per deciliter. We actually avoid it. Or we'll plasmapherese the patients down, or we'll give an alternative therapy before we add in rituximab. So you want to be very careful. And if that IgM level goes up, anything that causes IgM-related morbidity, peripheral neuropathy, cold agglutinins, cryoglobulins, will all get worse. Now, the other problem with rituximab is that over time, you do see normal B-cell depletion, and as a result, you do see hypogammaglobulinemia with recurrent infections, necessitating many times IVIG usage. And then very weirdly, patients who get rituximab can also develop a late intolerance. This usually happens, a few cycles into induction or during the maintenance therapy phase, and it can be quite problematic. So you can see intolerance affecting about 10 to 15% of patients. They develop these severe infusion-related reactions, and oftentimes we'll switch them over to ofatumumab with good effect. Fludarabine used to be the darling of this disease, but unfortunately we did see a very high rate of transformation and acute leukemia. So as a result, fludarabine has kind of fallen out of favor. Bendamustine is very important. It's a very important drug. However, you do see prolonged neutropenia and thrombocytopenia, and even a small fraction of patients developing AML or MDS, which is why these days we tend to use 4 cycles of therapy, not 6, if at all possible. And in fact, most of the data that's been borne out from retrospective studies at the Mayo and at the Dana-Farber, and some work that's been done in Europe, seem to suggest that getting 4 cycles of therapy may be just as good as getting 6 cycles of therapy. So keep this also in mind. Now, bortezomib used to be also a very important drug for this disease. We still use it, not as frequently, but we see a lot of neuropathy and a lot of discontinuation, far more than you see even in myeloma patients. Now, a seminal moment in this disease, and what I'm going to focus on for the rest of the evening, is the discovery of the MYD88 mutation. This was accomplished in my laboratory thanks to whole genome sequencing. And in fact, the MYD88 mutation can be found in about 95 to 97% of all Waldenstrom patients. This is a very interesting protein, MYD88. It's part of the toll receptor pathway, and toll receptors signal for various bacterial and viral particles. But when you acquire the mutation in MYD88, it auto-fires. The MYD88 molecule coalesces and as a result, recruits a number of very important proteins, and you see this downstream cascade of pro-survival signaling. This actually is quite complicated. It's been worked out largely in my laboratory thanks to the work of Dr. Guang Yang, as well as the mother and son duo here, the Chens. But I do want to just point out what happens here, and that is that normally MYD88 is an adapter protein for toll receptors, and it turns on the NF-kappa B complex. How exactly it does that, involves a series of proteins, including Bruton's tyrosine kinase. But BTK is actually turned on by HCK, which is a Sarc family member that we discovered is actually upregulated by mutated MYD88. Its gene expression is upregulated, and this in turn is what activates BTK, and BTK, of course, turns on NF-kappa B. But we also recently discovered, and this is now being published in Blood Advances, is that HCK also transactivates the BCR complex, and as a result, you also induce BCR signaling through interactions with SEEK. Now, these maps are complicated, but at the same time, if you look at them, look at all the therapeutic opportunities, including, of course, the use of BTK inhibitors, which is what we're going to focus on in a few moments. Now, just a brief word about the second most common mutation in Waldenstrom's, and that involves CXCR4. This is relatively unique to Waldenstrom's. You do see patients called WM patients who are born with germline mutations in CXCR4, but beyond that, it's really unusual to see this in any other disease, at least, to our knowledge. And we have looked in other B-cell malignancies, and very rarely we found them in marginal zone and in DLBCL. But in Waldenstrom's, up to 40% of patients have these mutations. They occur in the C-terminal domain, which is an important regulatory domain. And normally, CXCR4 binds to CXCL12. I'll tell you about this in just a moment. But what I do want to tell you is that there's two types of mutations that you'll find in CXCR4. One is the nonsense class, where you end up inserting a stop codon that leads to truncation of the protein. The other is frame shifts, where you see deletions or insertions of DNA. The nonsense ones are very deleterious. They're the ones that are associated with the severe hyperviscosity. So this is why these days, as part of the workup, not only do we get MYD88, but we also get our CXCR4 mutation status determined. And CXCR4 is a receptor that normally, as I said, signals for CXCL12, which is made by the bone marrow stroma. This acts as a attractant for these cells to go to the bone marrow. Those patients who don't have mutated CXCR4 tend to overexpress CXCR4. So this is why you find Waldenstrom cells heading to the bone marrow. Now, what we have worked out in my laboratory when we first identified these mutations, again through whole genome sequencing and then characterized them, is that they induce downstream signaling, including AKT and ERK, that actually provide pro-survival signaling that actually leads to BTK inhibitor resistance. And you can actually reverse this, as these experiments show, by adding in a CXCR4 antagonist. You're all familiar with plerixafor. Back in the day, we called it AMD 3100. So this drug made us also think that in the future, if we wanted to, and I will show you the future is already here, that we can possibly drug CXCR4 and reverse this ibrutinib resistance. Now, I'm going to tell you a little bit about the trials that we ran. Once we knew that BTK was part of the signaling pathway, we were very keen in understanding, at the time we had ibrutinib that was being developed, and we were very keen to study ibrutinib. And we reported the activity of single-agent ibrutinib in heavily pretreated Waldenstrom patients back in the New England Journal in 2015, and then updated it in JCO in 2021. These are the data, which we just updated with now a 59-month follow-up. And suffice to say, most patients attained at least a minor response, major response seen in about 80% of all patients. And if you look here based on the genotype of their tumors, you see differences. If they had no MYD88 mutation, no responses. If they were MYD88 mutated and also had CXCR4, they had much lower major response rate, even VGPRs, 90% or better disease reduction. You see a big difference compared to the patients that had only the MYD88 mutation. And also, if you were double mutated, it took longer to get to those major responses, almost by 3 months. So what we did see here, and I'll show you other studies in just a moment that recapitulate this, is that CXCR4, much like we had predicted from our preclinical studies, was in fact impacting clinical responses. And this also turned out to be true when you looked at progression-free survival. Now, the good news is, at 5 years, still, the 5-year PFS was 54%. These were, again, heavily pretreated. 40% were refractory. 5-year overall survival, 87%. But look at the difference in progression-free survival. Again, very much impacted by the mutation status. No MYD88 mutation, they progressed very quickly. The ones that were double mutated had an intermediary sort of journey here. At 5 years, 38% were progression-free compared to 70% who only had the MYD88 mutation. So again, a big difference called on by CXCR4. We also updated the long-term toxicity of this study, and in fact, we saw that the AFib rate went up to about 13%. However, most of these patients continued with medical management on ibrutinib. Now, this is our frontline study. My colleague Jorge Castillo did the long-term follow-up of this study, for which I served as the PI. And this was ibrutinib monotherapy in treatment-naive patients. And, the good news was all these patients were MYD88 mutated. Good news was everyone responded, but you saw differences in VGPR and major responses based on CXCR4. At 4 years, the overall PFS was 76% PFS rate, but see the difference here based on CXCR4 once again. At 4 years, 92% progression-free if they only had MYD88, 59% if they had also CXCR4. So once again, CXCR4 is a problem. Now, for a little bit of my talk here now, I want to focus on the other BTK inhibitors that are being developed for Waldenstrom's. This includes acalabrutinib, zanubrutinib, and tirabrutinib. Tirabrutinib is being developed in Japan. There is interest now actually in developing this also in other indications. But I'm going to just put this aside for just a moment because it's being largely handled in Japan. And I am going to talk about acala and zanubrutinib. And just, of course, as you can see from the kinome profile, there are differences from ibrutinib. Some of them are actually decent differences. Like when you look at, HCK can be actually targeted by ibrutinib and zanubrutinib, but not by acalabrutinib. We don't know about tirabrutinib. And there are also other targets, some of which can actually have untoward effects. So this is why it's important to study each and every one of these drugs in patients with Waldenstrom. And so let me share with you the data from the acalabrutinib phase 2 trial. This was actually run by my good friend and colleague Roger Owen in the UK. And this included both treatment-naive and previously treated patients. The upshot of this was that with a median duration follow-up of about 27 months, these patients were identical to what we had seen with ibrutinib. The overall major response rates, even the progression-free survival, looked just like we did looking at the ibrutinib data. There were some differences in side effect profile. There were some headaches, at least noted early on in the first few months. I think many of you are familiar with this with your own CLL and mantle cell experiences. The AFib rate at this point was 5%, much like we had seen with ibrutinib early on. And, there was also a discontinuation rate, including for AEs in about 7% of patients on this particular study. Now, the big news, for the last year or two, and hopefully, going even forward, we'll continue to be hearing about the ASPEN study. There is going to be an update of this at ASCO, this head-on, first ever, by the way, head-on trial of 2 BTK inhibitors. This occurred before even the CLL study, was reported. And this generated a lot of excitement for the reasons I'm going to outline. There were 2 cohorts. Cohort 1 was only MYD88 mutated patients. Cohort 2 was MYD88 wild type. They have no MYD88 mutation, which I'm going to get to in a moment. There could be a little problem here with this interpretation too. But the MYD88 mutated patients were randomized to either get zanubrutinib 160 BID or they got ibrutinib 420 once a day. And those, of course, that were MYD88 wild type just got zanubrutinib as a treatment. Now, what did we learn? What we learned is that the major response rates were identical, meaning that both drugs are very, very effective. However, the depth of response numerically at this point favored zanubrutinib. There were more VGPRs to be seen on the zanubrutinib arm, but this did not reach statistical significance at this point. This is one of the reasons why the ASCO update is going to be very exciting to see if there were, in fact, any differences further differences in this VGPR attainment. These are the responses by genotype. And I think there's just two pieces of news here to share with you. One is that there were more VGPRs seen with zanubrutinib among CXCR4 wild type as well as CXCR4 mutated patients compared to ibrutinib. However, both zanubrutinib and ibrutinib, as you can see, were both affected by also the presence of the CXCR4 mutation. So I think the take home here is that, it is CXCR4 is something we need to be concerned about for both ibrutinib and zanubrutinib. And I will come back because one of the points that's often raised is what does a VGPR mean? And I'd like to just kind of address that towards the end of my talk. This is really what made the news for ASPEN, and that is the differences in safety profile. In fact, with zanubrutinib, far less AFib, both for all grades as well as grade 3 or higher, lesser diarrhea, lesser bleeding, but more neutropenia, including grade 3 neutropenia. However, this did not generate an infectious signal. In fact, you can see here that, in fact, there were just even fewer infections at grade 3 or higher that were seen, again, numerically for zanubrutinib. There was slightly more GCSF usage. So this is, a concern for this drug. But contrary, for ibrutinib, there are other concerns. And so you have this yin and yang, with AFib being a major concern for ibrutinib, cytopenia and particularly neutropenia with zanubrutinib. And so as a result, I think, as I will discuss at the end of my talk, keeping in mind the patient and having now the gift of multiple BTK inhibitors is important because, it gives you an opportunity to use these drugs and direct them towards individual patients based on how they're presenting. This study did lead also to FDA approval. And also, as you know, in Canada, zanubrutinib was also approved. Ibrutinib was also approved by the FDA with the pivotal trial that I showed you earlier. Now, what I think is also important to say is that when you see the differences in AFib in particular, you see over time, zanubrutinib kind of stabilizes, but, ibrutinib AFib rate continues to increase over time. Now, just a word about the cohort 2 of the ASPEN. This was, again, MEDI88 wild-type patients. And with ibrutinib, we didn't see any activity. With zanubrutinib, we were pleasantly surprised to see that it was actually quite active. In fact, the major response rate was 50%, and overall response rate was 81%. Now, and some of these responses were very, very durable, as you can see here. I think this is actually genuine. It's real. But some patients in here had very little, if no, bone marrow involvement. And it's quite possible that they may have been misgenotyped. And we do know now from a study that we published just recently that patients who have low bone marrow involvement often are missed, for their true underlying genotype. By predominantly NGS when it's used, and sometimes even by PCR. So important to keep that in mind. But still, I think, look, some of these patients had, up to 90% involvement. It's hard to think that they got missed. And so I think this now represents an option for the MEDI88 wild-type patients and one to keep in mind. Now, a big question for all of us is what to do with a patient if they're having intolerance to treatment. And of course, with ibrutinib, we see this. This is a study we just presented at ASH by my colleague, Shana Sorosiak. And it involved 385 patients that we followed who had been treated with ibrutinib over, as you can see, nearly an 8-year time span, 1/3 of who were treatment naive. And many of these patients get all kinds of side effects because of the drug, arthralgias, cardiac, of course, cytopenias. And this actually ended up, prompting dose reduction in about 1/4 of all patients. The median time to dose reduction was about 7 months, and older patients were more vulnerable. And there were some patients who required yet a second dose reduction, about 27% of those that were initially dose reduced. This occurred at a much later time point at a median of 23 months. But I think the take home here is that despite the dose reductions, hematological responses were maintained or improved in the vast majority of patients. Now, at this last meeting, what caught my eye also was the Shadman study. This was a very interesting study, because it proposed switching over patients intolerant to ibrutinib or acalabrutinib over to zanubrutinib. They could go on 160 twice a day or 320 once a day. The vast majority of them went on 160 twice a day, but 320 once a day is also an approved dose here in the United States. And as a result, you can, in fact, look at this data as being consistent with what, one might be able to use zanubrutinib with. In this study, CLL patients, along with Waldenstrom patients, were included. There were also other histologies, as you can see. Now, what did we learn? What we learned is, I think, a very good lesson, that 60% of all ibrutinib patients and 70% of all acalab patients who then went on and got zanubrutinib did not have recurrence of their intolerance event. And despite this, their responses were still maintained. So I think this really does show us why it's good to have these new BTK inhibitors, because they offer us the opportunity to switch over patients when, in fact, they may have side effects related to other covalent BTK inhibitors. Now, I want to tell you that this study was published last year. I'm very proud of it. This shows us that we can actually go after public enemy number 2 in Waldenstrom's, that being CXCR4. We did this study with ulocuplimab. It's an antibody that binds to CXCR4, prevents CXCL12 from engaging CXCR4. And we gave this along with ibrutinib in CXCR4 mutated patients who had symptomatic disease. The ibrutinib was started on day 1 and continued until progressive disease or intolerance. And the ulocuplimab was given over a 6-month period and then stopped. And this was a dose escalation phase 1 study. What did we learn? We learned some very interesting things. First of all, these patients behaved like they didn't have the CXCR4 mutation. Their median time to major response was the same as we see with CXCR4 wild-type patients. And the median time to progression-free survival at 2 years was 90%, much like we see with CXCR4 wild-type patients. So unfortunately, BMS decided to discontinue development of ulocuplimab, which was a major disappointment for us. They didn't see a signal in myeloma or AML, but this was still a study that was demonstrative. And for this reason, now we are working with another drug called mavorixafor, which is an oral antagonist of CXCR4. It's built on the plerixafor backbone. And at this last meeting, I did present some of the preliminary safety data as well as some of the preliminary efficacy data. It's really still too early to understand the impact on efficacy in this disease. But suffice to say, the two drugs, could be given together with decent tolerance. Now, my colleague Jorge Castillo ran this study for us of venetoclax in previously treated Waldenstrom's. I really do want to acquaint you with this data because it is exciting, because the study was done in heavily pretreated Waldenstrom patients. Some had a BTK inhibitor before, some didn't. And this was for a total of 2 years of therapy, and then all therapy was stopped. What we learned here is that regardless of their prior BTK inhibitor exposure or CXCR4 mutation status, they all seem to respond relatively similar. Major response rate, 81%, and the median PFS in the study was 30 months. So this really does establish venetoclax as an important new therapeutic for treating Waldenstrom's, and one that we can consider after a BTK inhibitor. The data was presented and published in JCO just recently. Now, one of the things we've been excited of is this is one of the lab studies that came out of my lab about 8 years ago, and that is to show that inhibiting BCL2 with venetoclax also induces apoptosis or promotes apoptosis in the setting of ibrutinib, regardless of CXCR4 mutation status in these models. And this is why Now the study that we're running is combining ibrutinib and venetoclax in treatment-naive patients. We're giving this for a total of 2 years of therapy, and then we're stopping and we're observing the patients. For the first month, they're getting ibrutinib alone. Then we're titrating up the venetoclax, and then the two are given over the next 22 months. I'm very excited about the study. We'll see in good time both the safety and efficacy of giving this combination, which of course has turned out to be a very important combination for CLL and mantle cell lymphoma due to the reduction in disease that has been seen. Now, there's also interest in combining bendamustine and Rituxan with BTK inhibitors. This is the Philo study that was published a few years ago looking at Benda-R in Waldenstrom's. Note there that the MYD88 wild-type patients progress sooner, but you see that the CXCR4 mutation status could be overcome with this combination, which is why there in Canada, my other good friend and colleague Neil Berenstein is running this important study combining bendamustine and Rituxan with acalabrutinib, the so-called Brown study. I think this is going to be a very, very instructive study. So if you have patients who would be eligible for this, please consider this study because I think it will help us better understand how to position BTK inhibitors in the setting of patients who carry the CXCR4 mutation. Just a few words about patients who become resistant to covalent BTK inhibitors. This almost always in Waldenstrom occurs because of the BTK CYS481 mutation. This is where ibrutinib, Zanu, acala, tirabrutinib bind to. And so LOXO 305 is a novel non-covalent BTK inhibitor. You might have already heard about this drug, but it binds at a very different site on the BTK protein. And in our laboratory, we were able to demonstrate in these models that there is selectivity against MYD88 mutated tumors by pirtobrutinib. But more importantly, when we introduce the BTK CIS mutation in our models, and you can see resistance with ibrutinib, you can see how pirtobrutinib is able to overcome this. Now, another good friend, Mike Wang down at MD Anderson, has been running the so-called Bruin study with multiple different histologies and was able to actually show that in the setting of pirtobrutinib, they were seeing very robust responses among their Waldenstrom patients who had previously been exposed to a covalent BTK inhibitor. And so at my institution, Jorge Castillo and Shana Sorosiak are now running a dedicated phase 2 study of pirtobrutinib in Waldenstrom's macroglobulinemia. Now, the good news is that with these studies, we now have, more choices on the NCCN guidelines, both in the primary as well as relapsed refractory setting, and very pleased that not only is ibrutinib now a category 1, but zanubrutinib, because of the ASPEN study, has also been added as a category 1. This is also true in the previously treated setting, and also acalabrutinib was added as an other recommended treatment in previously treated patients. Now, just one word around peripheral neuropathy. I mentioned earlier, this is actually a very important manifestation of the disease. This can occur for multiple different reasons, the most common of which is a sensory demyelinating neuropathy related to IgM binding to the myelin sheath around nerves and destroying that myelin sheath. You can more rarely see amyloid and small fiber neuropathy, which is why getting an EMG workup is important, and also testing for the MAG antibody. So at my institution now, another very important trial is this acalabrutinib plus Rituxan in IgM MAG positive peripheral neuropathy. They can be patients who don't meet the Waldenstrom criteria. There are these MGUS or IgM problematic patients who can also be eligible for this study. As a result, they'll be getting acalabrutinib for a 4-year time span, along with 2 cycles of rituximab as part of this endeavor. I mentioned to you earlier Bing-Neal syndrome. This is actually a very difficult thing to treat. At least it used to be in the old days. We used to use high-dose methotrexate. Not too infrequently, we ended up with toxicity and little benefit. So if you are considering, treating these patients, do keep ibrutinib in mind, because particularly at the higher dose of 560 once a day, you do see good CNS penetration. This is a paper that we published in BJH many years ago, but it showed you that you could get good CSF levels. Even primary metabolite of ibrutinib could be detected at meaningful levels. And you can see robust responses. I mean, this was probably one of the worst cases that we had. And you see really what a benefit just a few months later occurred with the ibrutinib. My colleague Jorge Castillo did publish in Blood a follow-up to this initial paper with a much larger series of Bing Neel patients. Now, I just want to come to a conclusion here by just saying we're blessed that we have all these new BTK inhibitors. I think there's still some, rationaling to be done depending on the individual patient as to which one you might want to think about using. There is this question around convenience and compliance where maybe giving ibrutinib once a day is preferable to giving a drug that might have to be given twice a day. However, there is data with zanubrutinib for once a day and an approval for zanubrutinib for once a day usage in the United States. For patients that might need a deeper IgM response, think about, again, the neuropathy patient as an example, you might want to prefer zanubrutinib because you can get more VGPRs. For Bing-Neel syndrome at this point, we prefer ibrutinib because most of the literature is there. However, there is actually one case report now of zanubrutinib efficacy in Bing-Neel. I'm sure there'll be more data to come. For patients that are predisposed to arrhythmia or bleeding risk, you might want to favor zanubrutinib just because of what we've seen with the ASPEN data. Conversely, if they're neutropenic or pancytopenic, you might want to prefer ibrutinib. If they're intolerant to ibrutinib, then of course we have very nice data now from Shadman for zanubrutinib. There is also switchover data, but not in Waldenstrom's, but in CLL with acalabrutinib. And then mind you, this comes up all the time. If somebody is resistant to a covalent BTK inhibitor, should I just switch over? Well, not to another covalent BTK inhibitor because most likely they have the BTK cis481 mutation, and this certainly can be tested for. But maybe a drug, and this pirtobrutinib can be perhaps one of the drugs we can consider. This is currently still investigational, and so it's important to keep in mind that eventually we'll be getting these drugs, both in the U.S. as well as in Canada. And with that, I'm going to stop. And again, I want to thank the Waldenstrom's Macroglobulinemia Foundation of Canada for sponsoring this event, and also to BeiGene for providing the support and funding that made this program possible. And with that, Brenda, I'm going to turn it back to you.
Great, thank you so much. It's so exciting. This is really on the green growing edge of science and research to hear of all of these treatments and therapies. And like you're saying, just really blessed to have these choices that were not available just a few short years ago. So thank you for your work and research on that. There is a couple questions. I think you've already kind of addressed some of them. For the peripheral neuropathy, the testing and treatment, and I think you sort of covered that. Do you want to just touch upon it again?
Yeah.
I think it was the anti-MAG test.
Yes, yeah. So I think this is actually really important, in terms of how we work these patients up. By seeing this, I think we've all become neurologists too, because you see so many of these patients and you really want to get a good handle on how to manage them. But EMGs, if you get somebody who presents with sensory neuropathy, tends to be more sensory than motor, by all means, start with the EMG. It will show you whether the patient has a demyelinating pattern, which is indicative of an IgM demyelinating neuropathy, or if they have axonal degeneration, which occurs more with amyloid, although you can see in people that have had very long-standing IgM demyelinating neuropathy. If you see no EMG changes and the patients are complaining more of a burning sensation, you might want to think about small fiber neuropathy. And then as part of the workup, we do get the anti-MAG antibody. We get anti-GM1, although very infrequently. I'm going to say maybe in my career I've seen them only pop up in a handful, the BGM1 positive. Most times they're anti-MAG positive. and this will go along with a demyelinating neuropathy. So those would be the two essential tests in addition to doing a good exam. Usually with these sensory neuropathies, it starts in the toes, soles of the feet, and then somewhere between the sock line and the knee, it skips and starts involving the fingertips. And it's important to keep this in mind because it's a symmetrical pattern and it will just continue to worsen over time. But the pace at which it worsens can vary. It can be slow, in some patients it'll be very fast in others. If for patients that are very rapidly, and I've seen people in weeks go from just being totally normal to being, in a wheelchair, those kind of people might even pherese right up front just to get the IgM down and then start treating them. The goal of therapy is not to necessarily reverse the symptoms. I think the longer somebody has had the neuropathy, the harder it is to reverse. Our experience has been if it's been more than 2 years that they've had the neuropathy, it's much harder to reverse. So the goal becomes to just prevent it from getting worse. But if it's still, relatively early in the course, I think you have a good chance of reversing it.
Thank you for sharing that. I know within my support group, the peripheral neuropathy is the biggest life-limiting thing that people really are frustrated and struggle with. So thanks for addressing that one. Are there any treatment considerations specifically for familial WM, which generally follows a more aggressive course?
No, that's a great question as well. We published a paper a few years ago, which was in the pre-BTK era. So I think it's important to keep that in mind. And the patients who had familial disease, and just for our audience, up to a quarter of all patients can present with familial disease. The most typical pattern is you'll see other B-cell malignancies, even myeloma in up to first and second degree relatives. But there are more rarely patients that only have Waldenstrom, multi-generations of Waldenstrom. In fact, from Canada, I care of one family that has 3 generations of Waldenstrom. And so important to keep in mind that when they present with familial disease, they tend to be younger. We know that. The genomics we're still working on. We have some very important leads. But getting back to treatment, it looked like proteasome inhibitors did better for patients with familial disease, whereas with alkylators, they tended to not do as good. Again, this predated BTK inhibitors, predated more so even bendamustine. So it's hard to put into context, these more modern drugs. But if you look at the response rates today, I mean, they're very high with BTK inhibitors, and we did not see a familial impact with ibrutinib when we actually looked at that variable.
Okay, good. And here's a couple of these big ones, right? The big deal. So do you anticipate similar CNS penetrance between the BTKs for the management of Bing-Neill syndrome?
Well, I'm going to tell you, I was privileged today to some data that I was actually very excited by that, but because I think it was given to me in confidence, I'll just pause on sharing that openly here. But enough to tell you that I do think there are going to be big differences between the BTK inhibitors in terms of their potential to get into the CNS. So far, the data that we have for the most part is around ibrutinib, but I think we can get excited that other BTK inhibitors might offer us a different outcome, and that's why I'm excited. Today I was just privileged. It was a very interesting discussion we had, and we were just looking at the degree of penetration, for this particular drug, and it was just it made me very happy to see how the differences in structure could actually translate into differences in CNS penetration.
Wow, fabulous. I guess we'll have to wait to hear more about that, right?
Yeah, absolutely.
Awesome. Okay, and so just one more here before we wrap it up, unless there's any more that will come up in the box. But that last slide that you had was addressing like what to treat with whom based on what patient. What about those with CAD, the cold agglutinin? Sorry, forgive me, I haven't got all the wording down.
Yeah, cold
What do you do
agglutinin
for those?
disease. Yeah,
Yeah.
let's be first of all, I think around cold agglutinin disease, we're talking about Waldenstrom's related cold agglutinin disease because there is primary cold agglutinin disease, which is not mutated. But for Waldenstrom related cold agglutinin disease, I think you can consider a BTK inhibitor. I had one case on the frontline study that we ran where it was a very young woman who was a swimmer, and she dived into a cold pool, and she became profoundly anemic. She ended up she had cold agglutinin disease, very, very bad cold agglutinin disease, and her hemoglobin was down to like six or seven. Profoundly tired. And she was started on ibrutinib in that study, and in a short period, I mean, I'm talking very short period of time. I use her as a case demonstration. Her hemoglobin was now 13, and has done, exceedingly well. Went back to swimming, doing well. But the goal here is to get the IgM down. I think BTK inhibitors have a straightforward, path in terms of treating cold agglutinin disease. And the thing you got to remember is with a lot of these morbidities where the IgM is the cause of the problem, the goal is to keep the IgM suppressed, to get it down as much as possible, which is why, a zanubrutinib-like drug may have an advantage because, at least numerically, we'll see at ASCO if it's, what kind of data we'll see around the depth of response. But getting the IgM down as much as possible and keeping it down for as long as possible really are the goals. So whether it's cold agglutinins, cryoglobulins, IgM neuropathy, those are all things that we can better remedy with BTK inhibitors because of that ability to suppress the IgM production.
Wow. Well, thank you so much, Dr. Treon. This has been really great, and I hope our audience learns a lot about this rare disease called Waldenstrom's, and better knows how to treat the patients that do come to them. Thank you so much for your time, and we'll just
Thank you,
I'll hand it over
Brenda.
to Cam.
Thank you. And I just wanted, before I signed off here, to just let our audience know that the 11th International Workshop on Waldenstrom will take place in Madrid, October 27 to 30. You're certainly all invited. It's been on pause because of COVID, but we're really excited. We have two great chairs, Ramon Garcia Sanz and Jesus San Miguel, who have made enormous contributions to our field, but they'll be co-chairing this meeting, and it'll be a very exciting one.
Oh, I'm sure people are ready to travel, and Madrid sounds pretty nice for October.
Yeah. Thanks
Cam,
again.
over to you to wrap things up.
Thank yous for Professor Treon. It was a wonder to sit and listen to his presentation today. Extremely informative, and sharing his insights on his clinical trials and his dealings with all the various patients they have over the years of WM. It's been fabulous. Of course, none of this could have happened without the assistance of Chris Patterson, who's the administrative director of the Bing Center. And I'd also like to thank all the doctors who are currently present who have taken the time to listen to Stephen Treon speak. In addition, I'd like to thank the folks at Beijing once again for their very generous support making this all possible. The IDM and also the IDMF for their assistance in putting the technical infrastructure in place. And last but not least, all the volunteers for the WMFC. Thank you very much, and we'll see you at the next event. Bye now.